she's learned about NAMI support groups. Her involvement with NAMI opened the door to hope and a new career path in behavioral health. Ms. Stewart has led and coordinated NAMI support groups as well as NAMI's evidence-based practice program, Family to Family. She was a national state Family to Family trainer and in the past executive director of NAMI Maryland, and is currently a consultant and trainer for the UMB Evidence-Based Practice Center, also known as EBPC, where she works with public behavioral health provider agencies delivering EPB, Assertive Community Treatment, also known as ACT, and Family Psychoeducation, FEP. Ms. Stewart is the Johnson & Johnson Dartmouth Family Advocacy Team Leader for the Community Mental Health Program, and she has worked closely with NAMI families to embrace the recovery benefits of EBP-supported employment and to share her belief of recovery and mental illness.
Thank you. Thank you. Can you hear me? I can't tell. Okay. So I'm going to be talking about assertive community treatment. And has anybody heard of that? Raise your hand if you've... Oh, so some people know about it. That's great. I also wanted to ask if you know what an evidence-based practice is. Okay, so most people do, but if you don't, an evidence-based practice is a practice that's been researched and shown to be effective. And we know that if we follow the way the model was designed that was effective in research, that when we transfer that out into the community, it can also be very effective. And assertive community treatment is an evidence-based practice. Okay? So hopefully today, by the time we finish, you'll be able to answer some of these questions. You know, what is assertive community treatment? What does it really mean? I'm going to look at a brief history of the model. And when I was doing this, my original slides used to say for over 30 years. And when I counted up the time, it's actually over 50 years. And when I really look at it, it's almost 60 years. So it's a long time. And why is ACT important? Why is it that, we have these services? And the other question a lot of times is, why is it that there aren't more people involved in ACT services? Talk about the basic principles of ACT services and how you might be able to access those services in your community. Well, going in the wrong direction always is a good way to start. So here's a definition of what ACT services are. So it's an evidence-based practice designed to provide treatment, rehabilitation, and support services to individuals who are diagnosed with a severe mental illness and whose needs have not been met in the community. So, you'll hear me say this several times, it's not that they failed the system, it's that the system has not been able to meet them where they are. And that's why ACT is really important. Well, we'll go back to this again. All right, let's see. Let me give you a little bit of a history. So when I said this started back 60 years ago, it's hard to believe that the 60s is almost 60 years ago. And it started in Wisconsin, which coincidentally is where NAMI started, in Wisconsin. And it started out as an observation. So what people were noticing was that when individuals came into a psychiatric hospital, they would be in there because back in those days, people, as you know, stayed in the hospital for months at a time. And there was a lot of, work with people, teaching them skills, all kinds of things that were taking place in the community. And the plan was for hospitals to get people back into the community to be living. So what they found was once people were discharged from the hospital, they would return. And they weren't quite sure why that was happening. And so what they found out was that the services that were provided to them on an inpatient unit were not out in the community. And also that the people who needed these services really needed help to follow through and do things. And that was not available in the community. I'll get it by the end. Okay, so why is it not helping? Okay, so some of it's missing. And I don't know why that is, but I know what the slide says. So basically, one of the other issues that was being faced by people who were discharged into the community was that the services that they needed just weren't there. So, I mean, I don't know whether any of you are old enough to remember back in the 60s when they were, closing down the hospitals and sending people into the community, and there just wasn't enough housing, there weren't supports, and they were recommending that people get the kind of help that really wasn't available out in the community. The other thing that was an important thing to consider was that there was nobody out there to follow through and make sure that people were actually connecting and going to their doctor appointments, things like that. So there was a nurse on an inpatient unit who decided, hey, it's not working. What we need to do is replicate what we're doing in the hospital out into the community. I'm going to go back because I want to say, training with community living. So what they were doing in the hospital was training people how to take what they learned in the hospital out into the community. What they found was that still didn't work. So then there was something called Hospital Without Walls, and that's where I came in when I first started doing ACT services. It was just moving away from Hospital Without Walls, but it was still using a lot of the components of Hospital Without Walls. And what that meant was you got the exact same service in the community that you were getting in the hospital. Somebody would come to your house and give you the medication. Somebody would come to your house and take you to a doctor's appointment. Somebody would come to your house and do all of the things that they were doing on an inpatient unit, however you were living in the community. When I first started out on ACT team, I was on a PACT team, which is a program for assertive community treatment. And we sort of followed the Hospital Without Walls model a little bit. We were still learning how to do this. Over the years, there's really been a transformation because it's not just keeping people out of the hospital, it's helping people to recover. And what is recovery? And that's gaining a sense of well-being in the community and doing the kinds of things you wanted to do. And that was not a part of the initial Hospital Without Walls. And so there was a lot of resistance when we started with ACT services here in Maryland back in 1989. There was a little bit of a pushback because people felt like it was coercive. People felt like it was just really restraining people in the community, when in fact, in this day and age, that is not where ACT is. ACT has really moved forward to looking at recovery. It's been a bit of as a trainer, I trained the ACT teams in Maryland. As a trainer, it's been a real challenge because recovery is relatively new. When you think a program's been around for 60 years, and now you're asking them to change and not just focus on keeping people out of the hospital and giving them medications, you're asking them to really give people the skills and the supports that they need to make it on their own out in the community. So, yeah, I'm just going to use my finger, or not. So as I said earlier, one of the reasons that people were going back into the hospital was, people were expected to do certain things. People were expected to show up for appointments. People were expected to even make those appointments. People were expected to, get the help they needed outside of the hospital. And of course, if you know, many times part of the illness is denial or feeling that a person doesn't have a mental illness. So if that's the case, why would they even make an appointment or even go to a doctor? So this was what was happening when people were being discharged. And this happens today. Sadly enough, here in the state of Maryland, I looked at it the other day, we have about 28 programs that are providing evidence-based practice assertive community treatment, and we have 2 teams that are moving in that direction, 2 mobile treatment teams. But what I find is people are still falling through the cracks. People are not getting connected to ACT services. And so hopefully, just by knowing about it, it's the education, knowing what's out there and knowing what's available and asking for it. And hopefully today I will go over some of the main principles of what ACT services are, because if you don't know what's supposed to be happening and you don't know how to follow up with things, your family member or you may not be getting the the dose of ACT that you should be getting. So we talked about this. ACT is for people, again, for whom the system has not been successful. It's also for people with severe mental illness, and we'll talk about what that means. It's been defined several times today. Schizophrenia, bipolar disorder, major depression, the serious illnesses, the target population that the Behavioral Health Administration identifies as serious mental illness. Many times, the individuals that are enrolled in ACT teams are homeless. They've burned through their families. They've burned through every asset that they've had, and they are now on the street. And so many of these people are the people that you see every day when you're coming back and forth and going to work. The job of the ACT team is to, of course, help people to regain their mental health as well as their physical health, but also helping them to gain that recovery, getting back to where they want to be in the community. And that can mean a lot of different things to different people. The thing that I think is the most difficult, especially for families, is this whole concept that ACT services, nobody can force you into ACT services. They're voluntary. And many times, and as a trainer, this has been a challenge for me, because on one hand, it's voluntary, and the person has a right to choose what they want to do. On the other hand, they may be extremely ill. They may not realize they have an illness. And where does that fine line come between autonomy and neglect? And I think a lot of it falls onto the shoulders of ACT staff to be engaging, because you can't just ask somebody to sit for an hour and sign a bunch of papers when they don't think they have a mental illness, and then follow through and take part in the services that you're providing them. So this is the biggest challenge that I have, is getting people on ACT teams to engage and re-engage, and engage and re-engage people. And one of the issues that I hear, two issues that come up for me are, it's their right to refuse services, and we don't get paid for engagement, which is not accurate, but old habits die hard. Teams are supposed to be using assertive engagement techniques, and things like that could be something as simple as taking a coffee to somebody, or a hamburger, or, I know when I was on an ACT team, this one guy, the only way we engaged him was, we tried everything, and he finally said he wanted a pair of bunny bedroom slippers, and this was a homeless man, and he wanted cozy, warm, fluffy bunny slippers. Well, the psychiatrist went out and found these bunny slippers, I don't know where, but he wore them, and that was the trick. That's what it took. But it didn't happen overnight. It took a long time, and it took a lot of work on the part of the staff to figure out what it was that he wanted. And in the beginning, we were like, you're kidding, bunny slippers? How could that be so important? But for some reason, that was really important to him. So what does an ACT team look like? It's a transdisciplinary team, and a lot of times when I'm out and I hear people talk about multidisciplinary team and all that other stuff, I have a good visual at the end of this to show you what a transdisciplinary team really looks like. But basically what it is, the teams are made up of specialists, and I have that as one of my next slides, is the specialists on the team. But everybody has an area of expertise, whether that's the prescriber on the team, whether it's the nurse on the team, the therapist, or any of these people on the team, they all have a specialist. And part of being on a transdisciplinary team is to share that expertise. That doesn't mean I can write a prescription. It means that the nurse might be talking about medications, or the prescriber, the doctor, the nurse practitioner, and telling me, okay, so these are some things you might want to be looking for. These could be side effects of the medication. So even though I'm not a nurse, even though I'm not a doctor or a prescriber, I can go out into the community and see the clients I'm working with, and I can be looking for these things. I'm the eyes and the ears that I bring back to the team, because I'm looking for everything. I'm not just looking at their mental health. I'm looking to see, are there side effects of medication? You know, if it's hot, do they have an air conditioner or a fan, or do they have access to fresh water? All of those things, but we're sharing that information so that when I go out, I'm not just focused in my area. I'm looking at a big picture so I can really be taking care of the entire person. We talked a little bit in the beginning, and it's been mentioned before, about the target population. I hate the word target population, but that's what it's called. And again, these teams are designed for people who are extremely ill and people who have tried other things and it just hasn't worked for them. Not everybody is appropriate for ACT level services. Sometimes people come in there because, I don't know, family complains or neighbors are complaining, and then the next thing you know, they're sent over to the ACT team, but they may be somebody who already has a therapist, who already has a psychiatrist, who already is receiving some level of care in the community, or maybe they're able to go to a doctor's appointment if somebody takes them. Again, not everybody, you know, ACT is highly intensive, so it's not appropriate for everybody. So that's why they have to do an assessment in the beginning to see if the person meets the qualifications or the criteria for acceptance into the program. One of the other things that they look at is, you know, is the person a high user of institutions? And institutions can be hospitals, emergency rooms, jails. It's not uncommon for people who are not connected to services other than ACT services, and even with ACT services, to go to an ER several times a day because they don't have maybe they don't have the skills that they need to manage whatever is going on, if it's a coping strategy or if it's symptoms of their illness, or maybe in the past that's the only thing that's been helpful to them is to go to the emergency room, so that's where they go. So hopefully on an ACT team, you know, people are working with that individual so that they can learn skills so that they know how to, I wouldn't say better manage their thoughts and feelings or behaviors, but a way so that they can really be more independent in the community and not relying on other resources. Same thing for psychiatric hospital beds. Ideally, the way an ACT team should work is ACT teams have the capacity to see people 24/7, 365. So if they notice that someone is starting to have some symptoms of their illness, or they hear from the family or someone that this person has stopped taking medications or is not answering their phone anymore, they can be really proactive and jump in and hopefully catch things before the person winds up in a hospital. That's the hope, okay? Oh, I really hate these things. So again, the service provision is based on the complexity of need, and because it's a broad range of services that are provided on an ACT team, I mean, they provide everything. The ACT team provides it all. They have the nursing piece for somatic health. They have the and education. They have the prescriber, and you know, many teams, and again, it's a prescriber. We used to say a psychiatrist, but now because it's in some of the rural areas, it's extremely difficult to get a psychiatrist. So they get nurse practitioners who are actually pretty good. I mean, I think they really are much less likely to to want to stay in the office. They really want to get out there into the community. That's been my experience with nurse practitioners, that they really get out there and do their nursing work out in the community, but they also prescribe medications. They also have, and I don't know, were any of you in here for the work plenary that was this morning, or the work, talking about benefits of working? So on an ACT team, there is a vocational specialist, and they are supposed to be following evidence-based practice supported employment, which is a little bit different than, encouraging people to get volunteer jobs. They want people to be out there and to be able to make money and to hopefully support themselves in the community, but also to be in jobs that are competitive, that anybody can apply for, not just set aside jobs just for people with a mental illness or a disability, and also, just integrating them into the population. Because the clients who come onto these teams require a lot of help, the staff ratio to clients is very, very low. So in an outpatient clinic, I don't know, how many clients do you see? I mean, how many on your caseload would you say, like 50 or 60, 70, 80, 90? Okay, so if you're out in an outpatient situation, you may be responsible for managing the care of 90 people. On an ACT team, the ratio is 1 staff member per 10 clients. Okay, so it's really intensive. So they have the capacity to do a lot of work with clients. They have the capacity to see the client, meet the client wherever they are in the community. That means at their house, if they're working at their job, it could be under a bridge, it could be wherever that person is and where that person feels comfortable. So that takes that whole transportation, I can't get there, all that stuff out of the picture. Also, by going into people's homes and by going to where the clients are, the staff gets to meet family members. The staff has an opportunity to see what the environment is that the person is living in. Is it a healthy environment? Is it a safe environment? What are the kinds of things that this person might need that they're not telling me about, but I can see when I go to their house? Again, anybody who's on an ACT team becomes the eyes and the ears of everybody and reporting that back to the team. Frequency intensity. So I guess as an outpatient, I don't know how often people are seen. Bob, once a month, once every 2 weeks. Yeah, so on an ACT team, in order to be doing excellent ACT services, that client should be seen 4 times a week. Okay? And not for 5 minutes, not just drop off the medication and leave. The ideal amount of time, the intensity of services that are needed is 2 hours a week. So that person needs to be seen by a staff person 2 hours a week and hopefully 4 visits. Now we know that's not always easy, especially in both urban and rural areas, because transportation and getting back and forth in traffic. I mean, I know the folks over in Montgomery County can be a long drive. Same thing with Anne Arundel County. It's a big county. It's all over the place. But again, when I see teams only providing 1 visit a week under an hour, I question, are they really providing the level and intensity of care that ACT teams really need, the clients really need? So again, if your family member or someone you know is on an ACT team, they should be seeing someone on a regular basis and not the same person. They should be seeing a minimum of 3 different staff people in a month, okay? When they say 24/7 services, ACT team members or someone on the team, there's an on-call, someone is always available. Even if you call in the dead of night for an emergency, you will not get an answering machine. You will not get somebody who says, oh, I'm sorry, you'll have to tell me what the problem is and I'll solve it. No, you get to talk to somebody on the team who knows your family member or who knows you. Sometimes, the other thing, the expectation is, if necessary, a staff person should be going out into the community when they're called, if they can't handle it over the phone. Most teams are able to handle things over the phone, and the good teams are really proactive, and they know who might be experiencing some traumas or some agitation or some behavioral changes or whatever. So they're aware of this, and they can be proactive and call the person. several times just to sort of keep track of what's going on. But I hear many times from teams, oh no, we're not going out in the middle of the night. Well, certainly if someone is armed and dangerous, you're not going out there. You're going to call 911. And many of the neighborhoods that people go into are honestly not very safe to go to at night, and as it seems now, even in the daytime. So again, it's using good judgment, whether you go out or not, but you should be connecting, you should be talking to the police, you should be talking to the emergency room. That's that connection. There should always be ACT involvement if you're a family member or if you are involved in ACT services. The state pays an enhanced rate for teams where they are providing a high level of care. So in order to bill at that higher rate, they have to see people a minimum of 4 times a month. That's the only requirement, is 4 times a month. How many times do you think the average client on an ACT team gets seen in reality? Many get seen 4 times a month. As a trainer, I find that really difficult. As family members and providers, it's important for you to know that they should be seeing people a lot more than that. And if they're not, the question is, why not? I'm gonna push this button again and see what happens. So what are some of the service objectives? Promoting symptom stability and the appropriate use of medications. In order to be on an ACT team, you don't have to take medication. It is your choice. No one can make you take medication. The team will work with you, whether you're on medications or not. Also, there's in some of the, outpatient clinics, when you don't show up for 2 of your visits, then that's it, you're out. Here on an ACT team, that doesn't fly, because the team is supposed to be able to come out to you and engage you and re-engage you, and if you don't show up for an appointment or you're not there when someone shows up, that could be a red flag, and that means the team is going to start looking and trying to reach out to you and maybe calling you more frequently or stopping by your house, things like that. Co-occurring disorders, they used to be called substance use, and back in the day it was dual diagnosis, which in the world of ACT meant mental illness and substance use. But now people have so many other things, somatic illnesses that go along with it. When we say co-occurring, we're talking about mental health as well as substance. Again, on each of the teams there are specialists who can work with clients, work with them in a stage-wise fashion of where they are and where they are in their readiness to make any change about the substances that they're using. Nurses on the team are there to promote physical health too, because you can't have good mental health if you don't have good physical health. And one of the things that we know with clients on ACT teams, they have a lot of serious somatic illnesses because for years they've been neglected. One of the reasons that people diagnosed with serious mental illness die younger than the average person in the population is because of smoking, substance use, lack of connectivity, a network of support around them, somatic issues. Think about it. If you don't have somebody on your case reminding you, hey, you need to go get your annual mammogram, or you need to go get this, or you need to see the doctor for that sore on your leg. If there's nobody that the person has a network of support that can reinforce those kinds of things, they go missed. And that's why it's important to have nurses on the team. Also, they help people to get their entitlements. Housing is a big piece. Many of the people are homeless who come to ACT teams. Getting housing in the community is important. So on many teams, there's a housing specialist who works with that person to help them find affordable housing. It says in the ACT model that there should be affordable, safe housing. Sometimes those two don't go together, But again, teams are encouraged to find safe housing for people. And it's not just about their mental health, it's also about helping them to develop a life. People who come to ACT teams, we know that they may have burned bridges, they may not have their friends may have, over the years with each hospitalization, sort of drifted away. So part of what the ACT team does is to help to reestablish that natural support. That natural support building is not, hey, we're their family. Because I hear that a lot too on ACT teams. Oh, we're their family. And my response to that is, oh, good, so you're taking everybody home for Christmas Eve, and they're going to spend the night with you and open gifts on the morning, right? Because that's what a family is. It's when you invite somebody over and you're doing this. You're there, but your job is not to be their family for them. Your job is to help to connect them and make connections in the community. Again, earlier today, there was a presentation on employment and working, and we know work is a real important factor in recovery, that people who work, surprisingly enough, it reduces their substance use many times. It gives them something to look forward to and something to do. It gives them meaning in their life. And that's a real big push on ACT teams, is to help people to find jobs in the community that they want to do. Not because there's a job opening at some place and we want to fill that job opening, but we want to know what is it that that person wants to do. That person can have really lofty ideas, like there was a client who wanted to be an astronaut. Team didn't say, oh, I don't think you can do that. The team said, tell me more about that. What is it that you like about being an astronaut? This was after they looked it up to see what are the qualifications, what did he have to do, did he have to go back to school? And the gentleman was like, yeah, that's a lot of school, I don't think I want to do all of that. So they teased it apart, and they found out that he really wanted to work at NASA. He wanted to wear a white coat and have his name on it. So what they did was they actually worked with the people at NASA, and they got a job, and he became the janitor. But because he wanted to be there around all the scientists, his job was in the daytime, so he could go when there were scientists there, so he could feel like he was a part of that team. And I mean, that was a pretty amazing thing. So again, we want people to really reach for the big things that they want, not to just settle for something because it's out there. I tell you. Okay, so these are the basic elements. In vivo services, we talked about that just a little bit, about meeting the person where they are. When staff is at the house, it shouldn't be, hi, let me talk to Johnny. There should be some communication with the people who are living in the house, education. Part of what the team's job is not just to work with the client, but to help people around that client understand what's going on. So educating families is a real big piece of what they do. And we know from the beginning, 60 years ago, that people need to learn skills where they are. It's one thing to teach somebody how to do laundry, but it's your washing machine in your own apartment or in your building might be very different than the washing machine that I'm teaching you on. So it's really important to be where they are to teach them the skills that they need. Teams are expected to go out into the community. They're not expected to provide services in their office. They're expected to be out there. 80% of their time, they should be out in the community doing services. On an ACT team, they provide everything. Now, within limits. I mean, they don't pull teeth. They don't do a lot of things that other medical type individuals would be doing, but they provide a full spectrum of services. The team leader needs to be a licensed professional. That's a social worker, licensed counselor, therapist, could be a nurse, a registered nurse. There's a prescriber on the team. These are full-time people. Registered nurse. For 100 people, most of the teams, the target is about 100 people, so they have 10 staff people. And Most of the teams have 2 or 3 registered nurses, which is a lot. Vocational specialists who only do evidence-based practice supported employment. Co-occurring specialists, usually there are 2 on a team. They offer individual as well as group treatments, and they also do their group treatments out in the community. They might be doing their group at a library room in the community because it's teaching the person, the skill set might be to teach them how to take public transportation to get to that library. When they're there, they can see the services that the library has to offer. It's really getting them connected to the community. And then I think the key piece on these teams is the peer counselor, and that's somebody who has a lived experience of mental illness and or co-occurring disorder. And those are the folks that are really I would say, have the most success of engaging people because they really can relate to what an individual is experiencing. Many teams, what happens is anybody here familiar with Montessori method? Okay, so you know that even though it looks helter-skelter and like it's a free-for-all, it's very structured. It's the same thing with an ACT team. It may look to the outside person, oh, we're just going to drive here, and we're going to go here, and we're going to do this. It's very prescriptive. It's very well planned. And so you have all these specialists on the team. That doesn't mean they can't help each other out and do other things. What it means is we want them to really be focused in their area of expertise. So if it's a nurse is concerned about health. Well, the nurse might be taking somebody to the grocery store. Is that part of her role? It could be if the person has diabetes and they need to learn how to shop in a way that's more appropriate for managing their illness. Or they may be taking somebody to the shoe store to get a pair of shoes because they may have some issue with their feet and they need to get a shoe that's going to give them the support that they need. So again, a nurse might be doing that. You might have, even like, as I said just a bit earlier, like the substance use person, co-occurring person, might be meeting somebody in the community, but part of that is helping them to learn a system to get out in the community and to find resources that are available. So that's psychiatric rehabilitation. So people are doing multiple things. I think the danger on ACT teams is that many times people become too general and they're just running around doing everything, when in fact we really want people to be focused on what their area of expertise is. Let's see. Multidisciplinary. So when you hear somebody's on a multidisciplinary team, basically what you see is you see a bunch of experts who are doing their own thing and they stay in that little box and that's what they do. If they play the accordion, that's what they're going to do. They're not going to switch over and play a bagpipe. So that's multidisciplinary. They've got a lot of different disciplines, and they're all doing their own thing. Here we go, interdisciplinary. So now the people are all doing the same thing. They're all playing the same music, but they're all doing, they're doing one thing. Each one's playing their own instrument, and they're doing their one thing. What ACT is transdisciplinary. So it's more like a jazz ensemble. So somebody starts, the next person jumps in, and they sort of connect and do it together. And that's how an ACT team works. Again, and I talked about this, the team approach, it's really important that everybody on the team communicate. Here's a picture of what a daily meeting might look like. Every staff person on the team is required to attend that daily meeting because that daily meeting is the most important thing you're going to do that day other than see clients. That is the time when you report what happened in the last 24 hours with every client. Every client, every day is reviewed. If there's a problem, if you know that somebody's cat died, you're going to mention that. It's going to be recorded so that you will have a list of 30 days or 31 days of little comments that were brought up in the daily meeting so that if I'm on vacation for 2 weeks and I come back and I want to know how Joe's doing, I can just look at this sheet and see over the last month or the last 2 weeks that I was gone what he's been doing and what's been happening in his life so that I'm not in the lurch. I know what to do if I get a call from someone. All right, so all the team interventions are strengths-based. We try to assess what's what strengths does a person bring to the table when they come? And we build on those strengths, okay? And I stress to everyone that all of your interventions are either clinical or rehabilitative. If you're not addressing a clinical need that the person has, you should be training them, a skill, teaching them, helping them to learn something so that they can become independent. It's all about recovery. So I have some more stuff here. Any questions? It's a lot of information. All right, yes?
Is this these act services across the whole state in every jurisdiction?
No, but you're in Baltimore City. There's seven in Baltimore City. 7 ACT teams in Baltimore City.
Is it just certain counties or?
I mean, I have a list at the end, but there are a lot of counties, but your son is in the city, right? Your son,
My son's in the city. I'm just curious in general.
yeah.
And it reminds me, some of the things that you're talking
Mhm.
about remind me of a lot of the same things that developmental disability is working on.
Mhm.
With incorporating
Right.
people back into the community.
Right. And here, it's a one-stop shop. Everything is provided in one place, so there's not a lot of brokering. Should be no brokering of sending people out to this place or this place. Everybody on the team knows exactly what's going on with each individual so that you can provide a higher level of care. Well, it depends. If you're in Baltimore City, there is a universal form. You just need to call your local, mental. Yeah, it used to be the Core Service Agency, now it's the LBHA. Just call them, and they can send you a referral form. And then they will send it to a team that would be appropriate. Fred, you had a question? Well, okay. So again, hopefully your son is seeing more than one person.
Yeah, there's always different people, but there's only one therapist
Yeah.
for that team for all 100 clients.
Right. Well, because not everybody needs therapy. A small percentage benefit from therapy. What people benefit from with this population is skill development, things that they don't have to live in the community. So again, therapy, one of the things I think is sort of confusing to a lot of people, sometimes the symptoms of the illness are not as noticeable to the client as they might be to somebody else. And so, trying to get to the bottom of all of this and figuring this out is not as important as teaching them how to go to the grocery store and how to save their money or how to manage their own apartment. So again, yeah, and that's pretty standard. That's pretty standard is what it is. And because if the person needs some kind of therapy, there's always somebody on the team who can do it. And also the prescriber. The prescriber is supposed to not just prescribe medications, but provide some brief interventions and things. But yeah, unfortunately, that's true. But other people on the team are able to do some of those things too. Not provide therapy, but to really provide some hands-on kinds of supports for the person. Sure. You had a question? Montgomery County? Okay, and that's when you should call your local behavioral health, the core service agency, and make a report. Because ACT teams should not have wait lists. So if you've been waiting for 2 years, that's a problem. And I understand what you're saying, and And you haven't heard anything, that's despicable. You need to report that. And you need, you're talking to the choir here. Don't get me started. But seriously, you need to file a written complaint, and you just need to keep doing that, because until the teams hear it from somebody who can do something about it, nothing will change. Please do, please do, please do, yes. Are all of them? No. Peer specialist is not, I mean, now they have peer certification, so they're supposed to be able to have that certification. Mm-hmm.
However, I don't have, a degree in such and such or a license and whatnot, so if there's something, that I can do on that team, even if it's drive somebody or something.
Well, it's a little more than that, because on the team, everybody's an equal, so it wouldn't be like you'd be the gopher taking people here and doing that. You would be doing some really critical things. But are you involved with any of the trainings that are going on for peers, for certification?
I teach the NAMI family counseling, however, not with the peers, but with something with the peer group
Right.
programs.
Right. I mean, that could be a start, but I mean, RAP planning, things like that. I can, talk to me afterwards, and I'll get your name, and I'll get you on a list, because they have these trainings all the time, and you can become certified, and these are positions on the teams that are the most critical, in my opinion. Yes.
So, I've been involved for 3 years with my daughter in and out of hospitals, in and out of intensive outpatient programs, residential programs, etc. Never heard about this. How come?
Well, that's why I'm here, because it's a best-kept secret. And, people should know about it, and people should be demanding it.
Families, there's nowhere for families to get information of all the services that are available when your child has, my child was mental health and substance abuse. There's not like one place to get the whole picture.
Well, on an ACT team there is. And where do you live? Which county?
Montgomery County,
Montgomery County has 3 ACT teams.
never heard of it. And she was recommended for residential long-term care. She left one program because she had, her insurance ran out, but then she was able to get into another program in Baltimore, which didn't make sense to me.
We can talk about that, because I think, yeah, I mean, it's really important, and if nothing else, just knowing that there are programs out there that can be helpful. I will give you my contact information. If you're having problems with teams, it's important to let your core service agency know and get it in writing, and also you can let me know, because I will follow up to see if things are being addressed in some way. Yes? There are 2 in Anne Arundel County. There's 2. PEP has 2 teams.
And they did come to the meetings for the person I was advocating for, but we never really got anything, because I think they felt like, everybody felt like the client was difficult. And so she got really bad services.
Well,
And so, I realize it's 2 parts to that, but what can I do about this?
let me just say one thing. ACT is designed for the people that are really challenging and difficult. Those are the people that are appropriate for ACT level services. That's number one. Again, in your county, it's Catherine Gray, and you need to contact her. As at the state level, what I'm doing is everybody here from the state? Okay, good. Oh, you are. Do you mind leaving? No, just kidding. No. I just want to say that, I mean, it's really difficult, because I hear a lot of complaints. I'm a family member, okay? And people find me, and I hear the challenges that the families are going through, and what can I do? I mean, I can call the team, and they don't call me back. I can call the core service agency, but it's not the same as a family member. I would put everything in writing, because until there's a trail, nothing is going to change, nothing. I mean, I'm just, no, you probably did a good job, but it does. But that's engagement. And you know what? That's what happens to people when, now I'm going to get on my high horse here. That's what happens when a team does not do what the model says. That is, engage, engage, engage. I don't care if it takes you 6 months. Engage, engage. When I was on the first team in Maryland, it would take a year sometimes just to get somebody to accept a cup of coffee from us to talk to us. But we went out there faithfully every Wednesday, same time, same place. Somebody would go out there every Wednesday. And finally, one day, the guy broke down and said, I like sugar in my coffee. It's like, okay, we'll remember that the next time, you know. But it takes time. And when somebody comes out and they see you for 10 minutes or 15 minutes and they say, we don't have this level of care, who does? This is the highest level of care outside of an inpatient unit. Yes.
So
Okay.
I know a family who has a son who won't leave the house, and they're 19 years old. So is this the kind of, how would you get him hooked up with that? Would you guys come from home? How would you refer him to, get that kind of support?
Okay. Again, every program has a different way of doing things. Now,
What are the programs in Montgomery County? Because she doesn't even know what program to talk to.
okay.
She tried to get him to go to outpatient programs for young adults and stuff, but he won't go. He just won't.
No, if he won't leave the house. Yeah, I mean, that's another, I mean, again, that's a person who's not able to function in the community, not leaving the house. I mean, what happens, and this is what happened to a lot of older NAMI families, that, the mother got to be 85 years old and her 60-year-old son was still living in the house and he'd never had any services because the mom took care of everything. And these are the kinds of folks that could be appropriate. Is his diagnosis schizophrenia? Okay, because and the reason I ask that is because there is an early intervention team, but we'll talk about that. Yes?
Are they capable to giving medicine to the child?
Yep. That's what the nurses do. The nurses come out to the house or in the back of a car or in a restaurant bathroom or wherever that person is. They get injections, they monitor their medications, they help them to learn how to take their medications. Some better than others, but I'm saying, again, I think until there's, and this is my NAMI advocacy, until there is an uproar from families with complaints of this isn't happening, nothing's going to change. We do. One team, but they have a very low census. So I can give you that information. I mean, they're currently serving like 42 people. They have room. Any other questions?
Is there any requirement that the treatment plan or goal be person-centered? And it's getting to this need. Is that in the regulation?
No, it's not, and it's in, because now the regulations, they have to go by whatever their accrediting body is. If it's Jacob, they changed their name, and Carr. Getting people to change how they do things, because again, having an overarching plan of doing better yoga does not cut it. And these are some of the, that's one of the goals that I've seen. That's not person-centered. Person-centered is really digging deep and asking more questions, open-ended questions, really finding out what it is that person wants, what's important to them. Because until you find that out, they aren't going to answer the door. Why should they? They're not going to be there when you get there because you're not doing anything for them. We have to be different than the traditional system. We have to meet their needs. We have to do what it is that's important to them. Yes?
One family member is in Connecticut. The first question is, does the same standard of act exist
Yep.
there?
Mhm.
Haven't heard about it at all. And secondly, ours is a Anna Symposium. So if the criterion about they have to consent, how do you get
And that seems to be one of the issues here, is that if they don't consent, they can't bill for them. But I think that they can I think there's a way to get around that. Now, I'm not getting any clear answers for that. However, you can't expect somebody who doesn't think they have an illness to sign up for any kind of treatment. Why would they? That's stupid. So part of what the job is to go out there and engage that person. They don't have to tell him it's for mental health services. What does he want? Does he want a new pair of bunny slippers? Does he want to have his own place to live? Engage him where he is. What is it that he really wants? Because that's what we can help you do. We don't have to talk about the mental illness piece. Well, okay, so there, and we can talk about that, because again, the way I usually do it is I go through the NAMI in that area. I call and I ask if they have an ACT team. Could they recommend an ACT team? And then I call the ACT team up and I talk to the team leader to find out what the referral process is. Because just because a person says no, and again, there's a fine line between neglect and autonomy. And this is my new thing, because I've seen people die because they don't think they have an illness and nobody wants to take their rights away, and they come out and they say, yes, this person is totally appropriate for ACT services, but we can't do anything because he's not interested. My answer is you can engage them. Okay. I don't know. We can talk, because I don't know. All right, my time's up. All right, thank you all for coming. I hope it was, if nothing else, you know it's out there and you know how to get it. And did you get my email address? It's bmstewart, STEWART, at som.umaryland, you have to spell Maryland out. SOM for School of Medicine .umaryland.edu. Shoot me an email. I do. I'm doing this again tomorrow, same time, same place, different place.